Hello, Michael. Hi, how are you?
How's it going?
Very good, very good. Everything all right. So
Glad to be here. I only wish I could be in Italy.
yeah, this must be much more fun if we can meet together in person. Anyway,
Absolutely.
hello, Luke.
Hi,
How
Jeff.
are you?
How are you doing?
Very good. How are you?
I'm fine.
Nice.
It's a good day to talk all together, even though it's better with real things. But
yes, but tell me more about this issue. So in France, semiplimum is not reimbursed, or what is the problem?
it's not financed. It's not. It has not been approved by the health insurance. The fact it's approved by the health authorities. It means that we can use it, but it's not financially covered. So we used it during clinical trials. We also had an early access program, but now it's ended, and we use other anti-PD-1 for squamous cell carcinoma.
Incredible.
It's because it's the health authority believe that the literature is not convincing enough to have the reimbursement.
Mm-hmm. Okay, so instead you are then using Pembro or what?
What we may, but pembrolizumab is very used in advanced squamous cell carcinoma here.
Okay. Ciao Mauro. È scomparso. He vanished. Ecco. Okay.
Hello, hello everybody.
Mauro, hello? Okay. Here. Okay. So I see you are still with your white coat. So it means you are still visiting patients at this time of the day.
Yes, actually we are working in the Lille. As you know, it's a non-Louis which is part of our school of dermatology. So twice a month we come here with residents in order to visit patients. So it's a sort of school class that we do twice a month. So we are working with patients, but also we are working with the residents.
I see.
Scusi prof, la sentiamo abbastanza male, prof Laibach. Adesso chiedo un secondo al tecnico se può mettere a posto un attimo l'audio del prof. Provi un attimo a parlare,
sì,
prof.
Ovviamente probabilmente la tua connessione non è perfetta.
Provi un secondo.
Come mi senti?
La sento, non la sento bene. Alessandro,
Eugenio?
Sì?
Lì è una questione appunto di banda, non è possibile sistemarlo, diciamo, lato Zoom. Se ha la possibilità di collegarsi a un'altra rete o provare con lo spot del cellulare, deve fare un check.
Comunque la sentiamo.
Provo il cellulare. Provo il cellulare.
Provi, tutto.
Tanto io posso prepararmi con la condivisione?
Sì, allora, dato che comunque sono 29, così iniziamo perfettamente in orario.
Okay. Now, I just want to clarify that we will try to have a kind of mixed language, because basically most, if not all, of the audience, dermatologists connecting to this webinar are Italian physicians. So let's say, of course, we will speak mainly in English, but maybe sometimes if also the Italian, let's say, discussant want to speak in Italian, is no problem, and we will have a mixed language. Ok? Se vuoi partire, siamo pronti.
Ok, perfetto.
Ah,
Alessandro, vai pure.
L'Acquerolo?
L'Acquerolo non c'è in questo, ci sarà nel prossimo. Ha cambiato.
Giusto, perfetto, ok.
Ha cambiato.
Possiamo, scusate, vedo che il professore Laibach si è ricollegato da cellulare, possiamo fare un attimo una verifica del suo audio?
Sì.
Ciao, come va? Sente?
Provi, scusi, riprovi.
Mi senti?
Sì, la sentiamo meglio di prima.
Spero che non si scarichi. Va bene?
Perfetto. Allora, chiedo a tutti di spegnere il proprio audio, diciamo, così possiamo iniziare. The turn off the audio, please, so we can start.
Ok. Parto allora?
Prego. Allora, buon pomeriggio a tutti. A nome di Mattioli Health, provider ECM del progetto, vi ringrazio per la vostra disponibilità e la vostra partecipazione alla terza puntata di questo importante progetto dedicato al carcinoma cutaneo a cellule squamose avanzato. Il focus odierno è l'immunoterapia e la terapia sistemica nella patologia avanzata. Ricordo che la progettualità è sostenuta grazie al contributo non condizionante di Sanofi. Ricordo ai numerosi partecipanti che ci sarà ampio spazio dedicato al confronto costruttivo e alla condivisione, quindi invito tutti a scrivere le loro considerazioni sulla chat oppure a porre domande che si potranno fare appunto scritte attraverso la sezione domande. Infine ricordo a tutti i presenti che questo webinar è accreditato a livello ECM e permette l'ottenimento di 3 crediti, questo dopo aver presenziato almeno al 90% del tempo totale del webinar ed aver passato il test di apprendimento che vi sarà inviato insieme a tutte le indicazioni stasera al termine del meeting. Allora, io rimango a disposizione insieme con il tecnico. Ringrazio tutti ancora per i numerosi partecipanti e tutta la faculty per la disponibilità e passo la parola al responsabile scientifico di questo progetto, il professor Argenziano. Grazie, prof.
Grazie Eugenio, grazie. Allora cominciamo questa terza puntata dedicata al carcinoma squamocellulare cutaneo. Come sapete abbiamo fatto con il Dermatology Practical and Conceptual Journal, che è il giornale di cui mi onoro di essere editor, un supplemento speciale dedicato a questa patologia, e abbiamo invitato gli autori di questi 5 articoli a presentare i risultati e un riassunto del loro contributo. Quindi abbiamo fatto un primo episodio dedicato alla diagnosi, alla stadiazione del carcinoma squamocellulare, un secondo molto interessante sulla chirurgia e sulla radioterapia di questo tumore, e adesso arriviamo al fulcro, anche un po' il motivo per il quale oggi parliamo più spesso di carcinoma squamocellulare, perché fortunatamente ci sono state delle grandissime novità in campo di terapia medica di questo carcinoma e soprattutto delle forme avanzate di carcinoma squamocellulare avanzato, localmente avanzato. E diciamo che abbiamo chiesto ad uno dei più grossi esperti di terapia, immunoterapia e terapia medica del carcinoma squamocellulare avanzato, il professor Michael Migden dell'MD Anderson ad Houston, che in pratica ha condotto i trial registrativi sostanzialmente della immunoterapia per questo tumore, di redigere appunto un paper di revisione sull'argomento. E quindi Michael is here. Thank you, Michael, for being here. I was explaining a little bit the project behind this webinar. So the special issue which was organized in, let's say, discussing the various aspects of squamous cell carcinoma, and now we come to the main topic, you know, the treatment of advanced disease, especially with immunotherapy. And together with Luc Thomas, I would like to present now, maybe afterwards I will present you the discussant. Luc Thomas is a professor of dermatology in Lyon and my best friend, not only because we are colleagues, but especially because we play together in a band. I'm the drummer and he's the guitarist. So it will be my pleasure to co-chair Michael Migden today. And please, Michael, if you like to start, we will enjoy your lecture. Maybe your microphone.
Thank you very much. You're seeing me, I'm assuming, yes?
Yes.
Yes.
Okay. Let me get rid of this. Okay. Well, thank you very much. I'm going to be talking about immunotherapy and systemic treatment of cutaneous squamous cell carcinoma. Here are my disclosures. So prior to current therapy, what did we have? We had basically chemotherapy agents, such as those listed here, platinum-based and others, as well as epidermal growth factor receptor targeted agents, as shown here. There was no FDA in the US, no FDA approval of any agent for this. And they were typically used as a single or in combination when surgery or radiation was no longer an option. And then from the article, we did have these tables of the prior systemic therapies, the cytotoxic agents in table 1 and the targeted therapies in table 2. And in general, in addition to having short progression-free survival, relatively short progression-free survivals and overall survival, there was significant tolerability considerations. Before we get into a lot of discussion about this treatment of this disease, it's important, I think, to recognize that by doing these trials and having therapies develop, we're really standing on the shoulders of giants, such as Dr. Allison and as well as Dr. Hanjo in Japan, who elucidated these receptors and ligands, without which we wouldn't have any of this. In September of 2018, cemiplimab became the first systemic therapy approved by the FDA for treatment of patients with metastatic and locally advanced CSCC, not candidates for curative surgery or radiation. So why immunotherapy for this disease? In particular, cutaneous squamous cell carcinoma has the highest tumor mutational burden of any cancer in the Cancer Genome Atlas, multiple times higher than melanoma. And it's the belief that, as in other cancers, higher tumor mutational burden is associated with better response to immunotherapy, probably because, or at least possibly because of increased neoantigen formation. Excuse me. We know well that immunosuppression is a risk factor for CSCC, especially solid organ transplant. And then in the phase 1 dose escalation study of cemiplimab in multiple solid tumor types, a single patient, a durable radiologic complete response was observed. This led to the development of a expansion cohort in the phase 1 trial specifically for these patients with locally advanced and metastatic disease. Very good results from that led to the development of the phase 2 registration trial. The data mature portions of the phase 1 trial for the CSCC patients and the metastatic cohort, which at that point was data mature, were published in the New England Journal of Medicine. Took a little bit longer to enroll the locally advanced cohort, and I believe this is likely due to the concept of really what locally advanced disease is, because people were so used to just operating these over and over again. So when the data maturity of the locally advanced was available, this article in the Lancet Oncology. And then the 1-year follow-up to primary analysis, looking at locally advanced disease, we see about a 45% objective response rate, notably a high disease control rate, around 80%. But disease control rate alone is sometimes questioned because it can be of a short amount of disease control. So a durable disease control rate with no progression for at least 105 days was also assessed, and that was a nice 63%. And it's important to note in this study that patients with regressive disease were allowed to remain on protocol if deemed in their best interest. And I'll come back to this later in the talk about a case. Taking a look at the waterfall plot of best change in target lesion, we see the majority of patients had a nice decrease in their target lesion. And you see here in green, these are the complete or partial responders, but you notice that the bidimensional Hoop criteria of a reduction of 50% as the bar to get to response was also met by these other lines in blue. And the reason they weren't included as responders is they just didn't have time to get their confirmatory imaging prior to the data cutoff. Looking at the swimmer spot, time to and duration of response, we see that the majority of patients have a conventional response that starts around 2 months. Although 7 out of 34 patients in this locally advanced group had an unconventional response, which took much longer, 6 to 10 months to even get to partial response. And then we noticed also that many that had partial response took quite a bit longer to get to complete response, perhaps another 6 to 10 months after a partial response. And then looking at the longer term follow-up at 43 months, we see, especially in the 2 metastatic cohorts, group 1 and group 3, a significant increase in the amount of complete responders from 6.8% in group 1 and 5.4% in group 3, up to around 20% in both groups. So that tracks along with what I was saying about needing the longer period of time to get to complete response. Looking at the progression-free survival and overall survival Kaplan-Meier plots, we see a nice flattening in both with longer follow-up. And then reasons why patients were not good candidates for surgery. I find this chart particularly interesting. So look at the first 2 columns as not getting surgery for one reason or another. First column is that the disease was just so overwhelming, nobody wanted to try to get around it, okay? And then the middle column, technically the surgery was possible, but it would have resulted in severe deformity or dysfunction. So in these 2 columns, no surgery, whereas in the third column, these were patients that had failed multiple prior surgeries. Okay, so taking a look at this, we see quite a bit of difference between the first 2 columns and the last column in terms of objective response rate and disease control rate. And some rationale for this has been put forward, hypothesized, one being that surgery itself can be immunosuppressive in that it can increase Tregs. Also, another thought is that surgery produces scar tissue and loculations that can interfere with normal immune cell migration. So why is this important? Well, if you know this, you might think seriously about not continuing to operate, or perhaps not even treating with surgery if it's an appropriate systemic patient at all, because it can impact objective response rate and disease control rate. So we have to think about this in addition to as we saw in previous slides, giving patients more time because we know it can be as much as 1/5 that take much longer to respond, not just 2 or 3 cycles. Looking at treatment emergent adverse events, and this is regardless of attribution, so this is not necessarily attributed to the study medication. We see the most common of any grade were these constitutional symptoms, and we have to remember that this is an older population, so things like fatigue, diarrhea might be showing up in that age group anyway. It's not until you get down to the around 10% do you see the potentially immune-related adverse events like hypothyroidism and maculopapular rash. Also, you should notice that the majority of these are in the lower grade, and when you look grade 3 or higher, it's relatively few. And in fact, the grade 3 immune-related adverse events were only 12. The only one that had 2 patients was pneumonitis. The rest of these autoimmune hepatitis, encephalitis, hepatitis were just 1 patient each. Now let's take a look at Keynote 629. This is pembrolizumab systemic therapy, and originally this trial was open to recurrent or metastatic cutaneous squamous cell carcinoma. So if you had a locally advanced disease that wasn't recurrent, you wouldn't be in this group. And it's important to recognize also that the locally advanced group was added into this trial. There was a subsequent update of the trial to include these patients, but the results and the approval came later from the time we originally wrote the article. So we're addressing here the original cohort, recurrent and metastatic CSCC, where it's around 35% objective response rate and disease control rate around 52%. So these numbers are lower than with cemiplimab, but these are not head-to-head studies, so that it's not really appropriate to compare them. And more patients were second line in this trial compared to the Empower study. So based on these original results in recurrent and metastatic disease, there was FDA approval, excuse me, for pembrolizumab. And then since that time, the additional information from locally advanced has led to FDA approval for locally advanced, but again, not in time when we wrote the article. So locally advanced disease is a multifaceted disease, has a wide range of clinical presentations. We have to think surgery versus immunotherapy. So I did this Mohs surgery initially. You don't see the original site, but it was one single area around here. And I got to where it was very difficult, very close margin, tumor in the periosteum, diffuse small nest, doublet single cells. I sent the patient, after I did whatever I could do, because I don't cut bone in the Mohs unit, to head and neck surgery for bone burring, where they performed additional resection as well, which was all reported as negative. And a free flap was performed. This was quite a large free flap. So this is the scalp kind of heading posteriorly, but this extended onto the forehead. And then some months later, there were noticed of recurrences, 5 of them, right at the perimeter of the free flap. So in this case, we've changed to disease that was a single apparent focus to in-transit field with no remaining clear surgical target. So this disease has typically, when we see this, it's spread out. There's not an easy way to approach these surgically. So after 8 months of cemiplimab, all of those 5, you can't see the others because they're on the forehead. I couldn't shoot them in the same shot, but all of them resolved. And I've seen this patient back years later off treatment, and he's remained disease-free. So a nice tool for patients that disease gets so disseminated and hard to attack in any other way. And then looking at this patient, so it's not always these huge tumors, which I don't have an example today, but I have many examples that you just look at and say, oh, that has to be, systemic therapy. Sometimes it's a patient like this, where this patient had a full thickness tumor on the nose with this nasocutaneous fistula into the vestibule and was planned for rhinectomy. So rhinectomy, you say, well, it can be treated surgically. Yes, but maybe the patient doesn't want that. And in fact, this patient said, hell no, I don't want a rhinectomy, and came on to the study. After 12 months of cemiplimab, not only was his disease gone, but he regranulated his nasocutaneous fistula. Typically, fistulas don't close, but for some reason, I've seen this in several cases with immunotherapy. It's important to note also that his biopsies were negative after only 4 months of treatment, but it took quite a bit longer to have this granulate in. So is rhinectomy a good option? So I think in the face of available therapies, we should be not so quick to consign patients to a surgical outcome that surgeons may find acceptable, but patients may find devastating. And prosthetics may not adequately address such an outcome. And I fully support patients who are willing to accept risks, such as those with immunotherapy, to avoid an outcome like this. So let's take a look at varied response to cemiplimab in patients with locally advanced disease. So this patient at screening had this type of recurrence at the perimeter of a forehead flap. History of many large surgeries, many several free flaps and radiation. After 2 months of cemiplimab, he looked like this. And because his clinical assessment of this lesion was so much larger, he had to be deemed as having progressive disease. So he was a progressor as far as the trial went. And his data was one of those who ended up in the progression category. But the patient said, I feel great. And remember, I showed you in an earlier slide that patients with progressive disease were allowed to remain on study if deemed in their best interest. Patient felt great. He wanted to continue. And so after a total of 5 months, now it's starting to look different. It's starting to look better. We're clearing in the center. And then we have to ask, was this progression to begin with? Is it still progression, or is it something else? Was it pseudoprogression, where it was just a big inflammatory response and showed up looking like tumor, but actually was inflammation? Was it variable response, where the patient just didn't respond to begin with? His tumor kept growing, and then at some point, something in the immune system worked and he started responding? Or was it subclinical disease, where it was just hidden by the free flap, started to come up through the free flap where you could see it? Was it radiation recall? And I've experienced this in multiple patients. So we have a radiation field, we put them on immunotherapy, and the whole radiation field can light up. After a total of 7 months of cemiplimab, the patient had both a pathologic and clinical complete response. But for the purpose of the study, his case was considered progression. So future therapies. So I conceptualized and presented to Regeneron this concept of injecting cemiplimab directly into lesions. And we've done multiple cohorts, and we have new cohorts coming of doing this, injecting cemiplimab directly with the goal of having targeted delivery and trying our best to minimize the systemic exposure. So this 2 centimeter angry SCC, and it had to be only 1 to 2 centimeters because the FDA didn't want us starting this with larger, higher risk tumors until we had proof of concept. So after 7 visits, this was 6 injections, completely gone on the target lesion, but the hypertrophic actinic keratoses remain. So in addition to PD-1 blockade, what else can we do? Well, we can increase the tumor infiltrating lymphocytes as combination therapy with the goal to boost immunogenicity while improving effector cell activity. So you think of the anti-PD-1, cemiplimab removing the brakes from the immune response, and then an oncolytic virus such as RP1, which is a genetically modified herpes virus, to include GM-CSF region, and also one that increases cell-to-cell adhesion. So then when one cell lyses, it takes the next cell down with cemiplimab. So you rev the engine and then take the brakes off with the goal of improving response. So this is randomized 2 to 1 for patients receiving the combination versus just cemiplimab IV. So the RP1 is intratumoral, the cemiplimab is IV. This is the schedule of treatment. And then in conclusion, prior to immunotherapy, systemic therapies had relatively short progression-free survival and overall survival with tolerability considerations. Cemiplimab showed substantial anti-tumor activity, durable responses, and acceptable safety profile in these advanced CSCC patients. Pembrolizumab data and approval has also been discussed. Although most responses are rapid, some unconventional later responses have been noted with cemiplimab, and therefore we should be not too quick to judge after a couple of cycles. Neoadjuvant, adjuvant, and intratumoral cemiplimab local delivery studies are underway, and this may provide benefit over surgical therapy alone. RP1 oncolytic virus combination therapy is being studied, as well as I have a study for RP1 virus as a single agent in transplant patients. So I want to give a big thank you to Dermatology Practical and Conceptual Journal with Editor-in-Chief, Dr. Argentono. Thank you.
Thank you, Michael. Wow. So let me first introduce our 4 discussant, i nostri 4 discussant. Comincio da Mauro Labac, professore di dermatologia all'Università di Padova, e poi abbiamo, anzi in realtà sono 3 perché Paola Queirolo non parteciperà a questo evento, ma sarà con noi al prossimo. Poi abbiamo Tania Rinaldi, giusto? Non Gaetana, Tania, giusto?
No, è Gaetana.
Lo so, però come ti chiamano normalmente?
Tania.
Ecco, allora noi preferiamo chiamarti con il nome che usi abitualmente.
Il nome comune.
Esatto. Quindi Tania Rinaldi, oncologa medica presso il Policlinico di Palermo, e infine Franz Wilhelm Barufaldi Price, e lui vive a Milano e esercita la chirurgia plastica all'ospedale di Guarda. È così, Franz?
He's muted.
Aspetta che non ti sentiamo.
Sì, scusatemi, avevo il microfono chiuso. Sì, io dirigo la chirurgia plastica dell'ospedale di Guarda, che è uno degli ospedali più grandi di Milano, dove il reparto di chirurgia plastica è, direi, il più grande della Lombardia, per cui abbiamo ovviamente a che fare con ricostruzioni post-exeresi tumorali.
Bene. Allora, forse maybe I can start a little bit the discussion because I'm really very curious about this new development, like for example the local infiltration of cemiplimab. What is your first impression? Is it useful as a systemic treatment?
I think for the size tumors that were studied, 1 to 2 centimeters, in my hands, I had very good results. And for the study, the cohorts that we have, we're not officially releasing data because we're adding new cohorts, adjusting the treatment schedule from 12 weekly injections down to half of that. And but in my hands, and I can tell you so far, both the clinical and pathologic response has been extremely high. So much higher than what was seen in IV therapy for the advanced disease. So, and then also the, I mean, I have a whole lecture on that, but the immune-related adverse events, although they did occur, there were no deaths, and there were relatively few that were grade 3 or higher. And so this is part of the concept where we inject into very dense tumor or into the intradermal space. And as all dermatologists know, that intradermal injections tend to release locally more than they do systemically. So this is all part of the concept of targeted delivery. This is a big deal for me because I want to have a treatment where no one dies, because let's be honest, what is really the most worrisome thing about immunotherapy? The risk of having a high grade, such as immune-related adverse event, and the patient dies. So if you have something that you show no deaths and you show good efficacy, that's a big step in the right direction.
Definitely true. Definitely true. Do you have any experience in this approach, Luke?
This is my microphone. Yes, we have some experience, but unfortunately in the setting of clinical trials. And I must not talk about it because I'm in the investigator group, so I'm sorry, but I cannot disclose. But the general concept of intralesional injection of immunotherapy is very interesting in dermatology, and we have interesting results not only in squamous cell carcinoma. So I really approve this approach, and I think this is a very promising one. And I also can say that the level of adverse events is much lower with this intralesional injection protocols. But that's all I can say. I'm sorry.
Very good. But it's good that trials are ongoing, and so that means that very soon we will have some new information about it. Tanya, qual è la tua...
I just wanted to add that I really strongly believe not just in local delivery, but in combination therapy. So 1-2 punch. We know that the targeted, the anti-PD-1s take the brakes off the immune response. But if you don't have adequate number of tumor infiltrating lymphocytes or suboptimal tumor infiltrating lymphocytes, it doesn't matter how much you take the brakes off, nothing much is going to happen. So if we can rev that engine, for example, RP1, which is from Replimune. Rob Coffin was the developer of TVEC. He sold that to Amgen and started his own company to do even higher tech oncolytic virus treatment. So they have RP1, RP2, RP3, and they keep adding insertions into the genome to have efficacy. Even the later stage ones have a CTLA4, such types of immune activating agents in the sequence for the virus, and I think that's really the future. That plus the anti-PD-1 agents.
Sì. Tania, qual è la tua esperienza personale con il cemiplimab? Puoi confermare così questi dati molto promettenti, molto eccitanti? Il tuo microfono, Tania.
Allora, voi sapete che io parlerò in italiano perché ho difficoltà in inglese, lo capisco meglio ma a parlarlo ho più difficoltà, quindi mi scuso con gli stranieri. Devo dire sì, io ho anche atteso tanto questo farmaco. La mia esperienza, ho visto che il professore Migen, penso che si pronunci, ha fatto vedere queste immagini che nella realtà clinica le abbiamo, diciamo, viste anche molto peggio. Bellissima questa, dico, in 4-5 casi ho avuto la possibilità di vedere questa cosa che lui scriveva anche nel suo articolo, di una risposta tardiva all'immunoterapia, che mette un poco ansia, perché sono anziani, perché spesso sono nel testacollo, ma ultimamente per esempio ho avuto pazienti che lo hanno avuto nella zona perianale, quindi pazienti anche dal punto di vista clinico particolarmente provati. La sensazione che la malattia va avanti è anche un poco scoraggiante sia per il clinico che per il paziente, per alla fine revertirsi in situazioni cliniche di grande risposta. Un poco più di ansia me la mette l'idea del neoadiuvante. La slide che il professore aveva messo su possibilità di pseudoprogressione, dico, qui credo che il professore meglio di me può dire che sul PD-1 e anti-PD-1 è difficile la pseudoprogressione. Gli anti-CTLA4 ci hanno insegnato la pseudoprogressione, gli anti-PD-1 un poco meno. Quindi forse voi che fate gli studi clinici dovreste dirci qualche cosa di più su cosa succede in questa cute. Infatti gran bella esperienza questa delle pancio cutanee per capire cosa sta succedendo intanto, perché certo è strano che abbiamo la sensazione, cioè io in quel paziente mi sarei spaventato in una clinica normale. Chi dirà al paziente guardi, forse lei aveva una cosa di 1 centimetro che poteva essere asportata, io la porto a convincerlo a un'immunoterapia e si ritrova col pataccone così, e quindi poi convincerlo che potrebbe rispondere, perché sappiamo che comunque l'esperienza di risposte tardive non è la norma, d'accordo? Lo abbiamo visto perché soprattutto negli squamocellulari, più ancora del melanoma. Io sono abituata a vedere tantissimi casi di melanoma, devo dire che lo squamocellulare spaventa anche un poco di più in queste risposte che ha. Per cui è sicuramente un bellissimo farmaco, anche se il mio pensiero è veramente quello che bisogna notevolmente anticipare l'uso di questo farmaco per sfruttare due cose. Una, l'eventuale probabilità di una malattia che va tanto in progressione e soprattutto nei G3 rispetto ad altri, diciamo, anche un G1 che è cresciuto tanto anche per trascuratezza dei pazienti. E dall'altro lato dovremmo anche andare a considerare la tempistica della risposta immunitaria, quindi forse anticipare i tempi ci potrebbe aiutare tanto anche ad ottenere più risposte e a fare chirurgie meno devastanti e deturpanti per i pazienti stessi. Se poi mi permettete, se il professore lei gira una domanda al professore, nel suo studio, e lui lo ha citato in un piccolo rigo in una slide, parlava dei pazienti trapiantati, che noi sappiamo che come probabilità hanno più possibilità di farsi gli squamocellulari, ma vorrei chiedergli la sua esperienza o la vostra comunque esperienza nel paziente nell'uso dell'immunoterapia nel paziente trapiantato, che non ha però altre possibilità. Quindi è un paziente che abbiamo scartato la chirurgia, è un paziente che abbiamo scartato la radioterapia. Voi come vi comportate quando avete un paziente che ha già subito un trapianto, per esempio renale, e quindi dovrebbe fare un'immunoterapia?
Ok.
Scusate se sono stata un poco lunga.
No, benissimo, benissimo. I will try to summarize what you said. Tanya was focusing mainly on these two aspects which were intriguing for her, meaning the late response of some patient to cemiplimab and this phenomenon of the pseudo progression. It's a little bit scary when you have a patient who do not respond, and so it's very difficult to convince the patient to continue the treatment even without a clear-cut response, or even more if it's showing this kind of pseudo progression. So the first question was, what is your let's say strategy, in this regard, and also concerning the renal transplanted patients. So in this category of patients, are you okay? Are you going smooth with the treatment, or you have some problems?
Well, thank you for that question. Yeah, I have some comments. So about the first part about pseudoprogression or not responding and how to decide what to do, how long to stay on treatment. These are very good questions. I think for pseudoprogression, it's very important to assess the patient's sense of, well-being. So if the patient says, I feel great, that's to me less likely to be true progression and more likely to be pseudoprogression. I believe in doing baseline annotated photographs. So when the patient comes in prior to treatment, you should take a skin marker and mark the perimeter of the lesion, not just the visible part, but the part you can palpate, and have that in your documentation so that that's the starting point. So if the lesion starts to look bigger, one of the tools I use is I go outside of the original baseline dimensions of the lesion and do some biopsies, because if you go far enough out and a centimeter or so out and you're still having tumor, and it was not apparent that it was tumor to begin with, that leans maybe more towards progression. If the biopsies come back inflammation only, that would lean more towards pseudoprogression. So I think those two tools, just assessing the patient's status. I have not seen people who were true progressors say, I feel great. And typically they have, other issues going on at that time. As far as, and I'm sorry, the second question was?
Yeah, the point of the transplant readout.
Right, transplant, I'm sorry. So as far as transplant goes, we know that people that get these agents can lose their graft. So if it's a kidney transplant, it's better to be alive and have your kidney die than to be dead. So I think that's the issue. We know it seems to be that some patients can maintain their graft even with immunotherapy, although probably the majority have some consequence or loss of their graft. I think this is part of the reason that I originally thought about doing intratumoral injection instead of IV, because why dose the whole body? You're going to get some amount of leakage, right? And we know with immunotherapy, it's not necessarily a dose response. So even a small amount of leakage could give you immune-related adverse events. The big question is, can you limit it enough so that people don't die? And then the second part of that is, can you limit it enough so that the risk of loss of a kidney is lower? And that's a question that deserves the study. And hopefully on down the road, if we continue with the intratumoral program, injections intratumorally, we can consider doing this with transplant patients that just have a high frequency, or at that point, maybe we can get approval to inject locally advanced tumors. I personally believe this is injector dependent. Like all intradermal injections, some people are better at doing it than others. It's a very tight space. The agent has to be released very slowly, allowing this sponge-like tight dermis or dense tumor to absorb the agent. Because if you try and push too quickly, you're either going to have it come out on the surface or it's going to come out in the sub-Q space. And we know sub-Q administration of things like immunotherapy are basically the same as an IV dose. So at that point, you're not really limiting any more, in my opinion, than an IV dose when you put the needle in the sub-Q space. Sorry, long answer.
No, but it's extremely reasonable what you say about renal transplants. You have to, to choose the way which is saving the life of the patient, and that's extremely. Franz, qual è la tua esperienza con il cemiplimab? Voi lo state utilizzando anche in combinazione con la chirurgia o come avete integrato la cosa?
Allora, ovviamente l'indicazione a utilizzarlo non lo diamo noi chirurghi, ma sono gli oncologi. Io non ho ovviamente l'idea che si debba a tutti i costi, pur essendo un chirurgo, operare i pazienti sempre, no? Anche perché ci sono delle zone del corpo che sono difficili poi da ricostruire. E giustamente, come diceva il collega prima, sono pazienti che hanno subito magari diversi interventi, hanno avuto recidive, nonostante a volte queste recidive avvengano su escissioni radicali, quindi è proprio, diciamo, la caratteristica del tessuto che porta poi il paziente ad avere delle riprese di malattia. La mia difficoltà in certi casi è legata al fatto che veniamo chiamati nei pazienti immunodepressi, non solamente trapiantati, a rimuovere il tumore, perché quando il tumore è aperto è un tumore che al di là della poi capacità di impallinare il corpo del paziente, è un tumore che facilmente si infetta. E l'infezione, soprattutto dai trapiantologi, no, è considerata una complicanza alla stessa stregua dell'immunomodulazione che può dare, diciamo, il farmaco. E quindi l'idea che magari il tumore rimanga in quella posizione e possa sovrainfettarsi e possa portare poi a una condizione sistemica impegnativa, difficilmente da gestire proprio per le caratteristiche di fragilità del soggetto, mi fa pensare che bisognerebbe avere un protocollo molto specifico per come intervenire nella modulazione del tumore. Trovo che sia molto interessante questo fatto di infiltrare localmente, che imparo adesso per la prima volta, onestamente, e mi piacerebbe capire, no, se per determinate sedi anatomiche magari la riduzione delle dimensioni del tumore potrebbe andare, diciamo, di pari passo poi con una ipotetica rimozione chirurgica meno invalidante che non quelle che purtroppo noi siamo costretti a fare a volte in sedi come gli arti, come la regione perineale, come diceva la collega prima, volto, ovviamente, e cuoio capelluto.
Certo.
Grazie.
So I will again summarize basically comments about the integration of surgery, the surgical approach with the systemic treatment, especially the neoadjuvant, let's say, strategy could be in the future a very good option. And in this regard, I was also very curious about this, what you said about the, let's say, the drop down of the response rate when you have tumors which were which got multiple surgeries.
Right.
You said because of the scarring process, because of something local which prevent the efficacy, so that the fact that the medication is arriving into the tumor or something like that. That's what you said, right?
Well, nobody knows for sure why, but the hypothesis is that either surgery producing more Tregs to slow the immune response down, just the act of surgery, or scar tissue inoculations preventing immune migration. These have been proposed, but I don't think anybody knows for sure. But if you know that it could drop your response, it's important to think of the systemic therapy for appropriate patients. Surgeons tend to start thinking that they have a hammer and everything looks like a nail and just keep operating and operating. So that may have served us when we had no good alternatives except for chemotherapy. But in the day that we have such tools as we have, it's probably better to get out of that mindset and start thinking about locally advanced tumors that may be appropriate for systemic therapy or in the future intratumoral therapy.
Yeah, no, definitely. I mean, for the moment, the indication for immunotherapy is those just reserved to those tumors which you judge not operable because maybe you are not able to remove everything, or because of the high disfiguration you give to the patient. But in my view, we have to really, as you said, change a little bit our approach to the problem, knowing that that you can combine. But if you like to combine, you have to start first with the medical treatment and then surgery, not the opposite. Otherwise it's a problem. Yeah.
Exactly. And we really need to expand our concept of locally advanced disease. I'm in favor of not making this definition too narrow, because I really believe that it needs to be on a case-by-case basis, and it should be a patient-centered decision. I have had patients come in who say, I would rather die than have another big surgery. Sure. So surgical fatigue, disfigurement, morbidity, all of these things. So you can say surgery, but you have to ask surgery at what cost to the patient, right? Yeah. So this should be the expansion of, locally advanced, not a good surgical candidate. It doesn't mean that it's totally inoperable, you see? And even at my institution, I fight with people sometimes because they say, well, technically surgery can still be done. And I go, well, great. Ask the patient how much he's thrilled about your plans.
Of course, yeah. No, totally agree. Mauro, che ne pensi? Tu sei più chirurgo o più medico?
No, zero chirurgo e siamo tutti medici, soprattutto medico, ecco. Ma intanto volevo fare una considerazione. Preferisci la faccio in italiano o in inglese? La faccio in italiano perché siamo quasi tutti italiani, e poi tu magari la traduci in inglese. Fai un sommario che mi sembra più corretto, un po' soprattutto per il 100 e passa, colleghi che ascoltano. Ecco, riguardo al discorso del trapianto, volevo dire che c'è invece ancora un'altra option, un'altra possibilità che noi possiamo fare, quantomeno nel trapianto di rene. Nel trapianto di rene, come ci capita in quei rari casi di caposi progressivo, si può espiantare l'organo e poi mettere il paziente in dialisi e fare l'immunoterapia. Perché se a un certo punto la questione è di vita o di morte, è evidente che il trapianto di rene ci dà questa possibilità, cosa che non ci dà il trapianto di polmone, non ci dà il trapianto di cuore, non ci dà il trapianto di rene. Visto che la domanda era specifica per il trapianto di rene, ecco, metterei come opzione anche questa. In un paziente in cui una neoplasia cutanea è in qualche modo inoperabile e ha solo l'immunoterapia come altra possibilità, un'opzione possibile è quella di espiantare l'organo, mettere il paziente in dialisi e effettuare l'immunoterapia. Questo per quanto riguarda, insomma, perché potrebbe essere utile anche esempio. Invece una cosa, ecco, noi non abbiamo un'esperienza diretta, ma abbiamo molta esperienza con pazienti che effettuano le immunoterapie per altre problematiche, in particolare col melanoma, pur non gestendo noi direttamente il farmaco. È una cosa interessante che abbiamo visto anche in quella iniezione intralesionale è che non sparivano i cheratosi attivi. E noi questo che l'abbiamo visto, pazienti che fanno gli anti-PD1, gli anti-PDL1 e che oltre ad avere per un melanoma metastatizzato e che hanno cheratosi attiniche o comunque piccoli carcinomi, questi non scompaiono. E questo è consistente con l'idea che ci devono essere molte mutazioni per fare in modo che questa neoplasia sia mutata, quindi con neoantigeni, e questo possa poi far sì che l'immunoterapia funzioni davvero. E questo l'abbiamo visto anche nei carcinomi basocellulari. Noi vediamo appunto pazienti che fanno l'immunoterapia in cui i carcinomi basocellulari, quelli superficiali, ma anche quelli piccoli nodulari, gli sclerodermiformi, assolutamente non risentono della terapia con l'antipidiuana. Quindi sono considerazioni proprio a sostegno del fatto che perché l'immunoterapia debba funzionare ha bisogno di una neoplasia altamente mutata. E questo potrebbe spiegare anche il fatto dei 7 mesi di risposta, perché come tu dici, aspettando un po' di mesi, a volte la neoplasia aumenta e diventa sempre più indifferenziata o sdifferenziata con neoantigeni. Ecco perché a volte quelle risposte a lungo termine che si osservano forse potrebbero essere legate al fatto che compaiono dei neoantigeni e che c'è bisogno di alcuni mesi per poterli vedere, insomma, apparire. Ecco, farei queste considerazioni sulla base un po' di quelle che sono le nostre esperienze del quotidiano.
Well, but this summary is a little bit more difficult than the previous ones. So, no, well, because this is much more technical. So, first consideration, yes, we totally agree on the fact that definitely if a patient is dying for cancer, we cannot preserve just a piece, to preserve the kidney, then the patient is dying. So definitely, we all agree. By the way, so let's put again the patient under, come si dice quando devi fare un explantation, un espianto? Non ho idea.
To remove the organ transplant.
Espianto si dice, espianto.
You remove the kidney, then you
transplanted.
Okay. Anyway, so we agree. The other consideration is very intriguing, meaning it's very often seen in the practice that you do cemiplimab for an advanced squamous cell carcinoma, but in a patient having lots of more lesions like actinic keratosis, also maybe more less advanced squamous cell carcinomas, and by the way, only the big tumor is responding, not the rest of the lesions. So this could be that really for the immunotherapy being able to work, you need a very high mutational burden in order to get the cancer responding. And I'm curious to hear your opinion about this point.
So I agree, higher tumor mutational burden. And immune recognition of the neoantigens is really important. But I think also a lot of these patients, at least mine in Texas, we have Texas fried skin, you know, so these are people who have had a lot of UV exposure. And just because they have a propensity to form new independent lesions, so these are new primaries, okay, whether they're in the state of actinic keratosis or Bowen's disease or onto full-blown squamous cell carcinoma, there's a different amount of heat in each one of these tumors. What I mean by heat is inflammation. My personal belief is that a lot of the actinic keratoses and hypertrophic actinic keratoses are not hot enough to take advantage of the onboard PD-1 blockade. And I'll give you an example. Sometimes on the studies, they had a new primary come up. I would circle it with a skin marker, take a photograph, plan to do Mohs surgery, which was allowed. And sometimes when the patient came back for the Mohs surgery, just the act of biopsying the lesion caused enough, in my opinion, enough inflammation that at that point, the PD-1 agent took care of it. So often when they came back, it had already resolved or mostly resolved. So I think if there's a way, again, to add more effector cells, more tumor infiltrating lymphocytes, heat up these lesions, you're more likely to see a response. And that's my belief why second primaries can often occur while immunotherapy is going on, and especially why in many patients, actinic keratoses don't respond.
I see. Very good point. Very good point. I have just a curiosity as maybe the last point of discussion. What about starting to think about a good combination between radiotherapy and immunotherapy? Are there trials ongoing on this in this regard or not?
Well, at the advisory board meetings, there's certainly a lot of discussion. There's a discussion both of, you know, can you combine radiation therapy with immunotherapy, but also in trials, in say adjuvant trials, post-operative adjuvant, do we really need to have radiation in every arm? The problem is that radiation for advanced disease post-operatively can be listed as a standard of care. So then it's like, for instance, example, NCCN guidelines in the US, and then it's hard to design a study and get approval if you're not giving them radiation. But it's been asked the question, do we really need radiation? And I have nothing against radiation. I think in the appropriate scenario, it's helpful. But I will tell you that from the patient's perspective, I've never met one patient who said, I love my radiation. So, and a lot of them absolutely hate it. If I suggest going back for a new lesion to be radiated, they start yelling at me, you know, because of how much they dislike it. So I don't know the answer. I think it's a reasonable question. You know, will the radiation trigger, you know, more release of more exposure to neoantigens? I think it's a reasonable question.
Very good. Luke, what about a closing remark from you?
Well, we have learned many things in this session. I must say that my experience of anti-PD-1 in squamous cell carcinoma is more devoted to patients with metastatic disease than locally advanced. But I will certainly think about few general considerations from this conference. First of all, I suppose that it's time now to think about treatment of locally advanced, even not too advanced disease with systemic treatment or intralesional in the case of clinical trials, because I'm really convinced that this is an interesting approach and that sometimes surgery is very aggressive to the patients and can be disfiguring on the face, but also with function lost on arms. And my specialty, as you know, is acral squamous cell carcinoma, and it can be a loss of function that is a very poor outcome for the patient. Second, speaking again about kidney transplant patients, I must say that we have treated several of them. Most of them, in fact, we made the decision in multidisciplinary tumor board to try this treatment. But I must say also that with metastatic patients, it's not too much of a problem, because the first step we have usually is to reduce the immunosuppressive drugs, and very often this results in the rejection of the graft, and in fact we have an unfunctional kidney after some time, and in fact treating these patients is not so much of a problem. But having said that, we have 3 patients I remind of who were kidney transplants with a functioning graft, and they were not reacting too poorly with the immunotherapy treatment. I must say that in France we are not using cemiplimab anymore for administrative reasons, but I suppose it's very similar with pembrolizumab, and at least 2 of them have a very functional graft with this treatment after more than 7 months for one and 11 months for the second one. So it's not always a desperate choice we made in multidisciplinary tumor boards, and sometimes it may help the patient. Having said that, there are many things we do not know, especially about combination treatments, local plus systemic, imiquimod plus, for example, anti-PD-1, or irradiation. We know that irradiation is interesting in melanoma, so why not in squamous cell carcinoma? There is a project of a clinical trial here in France with this irradiation. So we believe that many interesting things will come in the near future in the treatment of these patients.
Very good points, Luke. Very good, very good. Michael, any comments?
I just can't thank you enough for organizing this. My only regret is that I'm not there in Italy. I want to be there, you know.
Well, next time you come here and you eat a little bit of mozzarella.
Yeah. Absolutely. Thank you so much.
Thank you so much. Thank you to everybody. Grazie a tutti per essere stati qui. Grazie ai partecipanti che sono ancora numerosissimi insieme a noi in questo momento, e vi aspettiamo a questo punto per la ultima puntata in cui parleremo delle popolazioni speciali, quindi carcinoma squamocellulare in popolazioni di pazienti un po' speciali. Grazie a Lucy, a Eugenio, a Mattioli, grazie a Luke, a Michael e ai nostri 4 discussant, grazie mille e ci vediamo presto. Un bacione.
Ciao. Grazie a tutti.
Grazie a tutti.
Grazie.
Ciao, everybody.
Grazie a tutti. Thank you very much. Bye.
Thank you.
Bye.